Hey everyone, welcome to The Explainer. Today, we're diving into what is honestly one of the most fascinating clinical paradoxes in neurosurgery, the collapsed or slit ventricle. It's this wild situation where what looks like an absolutely perfect, successful shunt outcome on a brain scan could actually be a complex medical emergency, or paradoxically, literally nothing to worry about at all. Our goal today is to unravel this whole mystery, step by step, so you know exactly what you're looking at. Okay, let's just jump right into our clinical pathway for today. We're going to cover defining slit ventricles, categorizing the conditions, SVS pathophysiology, patient evaluation, and finally, targeted treatments. Starting right off with Section 1, defining slit ventricles and establishing our baseline. So at its very core, the term slit ventricles means exactly what it sounds like, the complete collapse of the ventricles inside the brain. But clinically speaking, how do we actually measure that? Well, based on survey data, a frontal-occipital horn ratio of less than 0.2 is most often the benchmark interpreted as representing slit ventricle syndrome, or SVS. Make sure you keep that specific 0.2 ratio in your back pocket as your baseline metric. And this beautiful watercolored visual perfectly illustrates exactly what we're talking about. If you look at this non-contrast axial head CT, you can see that the frontal horns of the lateral ventricles are barely even visible. They're just these tiny, tiny slits. You can also spot the tip of the ventricular catheter resting right in the middle of that collapsed third ventricle. It's a really striking image. Now, here's the catch. Seeing that collapsed state on a scan isn't automatically a reason to sound the alarm. Slit ventricles can actually pop up in a few different contexts. For a huge number of shunted patients, especially younger ones, this is actually a totally normal occurrence. But it can also be caused by overshunting, an entrapped or isolated fourth ventricle, or even seen in some patients with pseudotumorous cerebri, where they have those slit-like ventricles but deal with consistently elevated intracranial pressure. Moving right along to Section 2, categorizing the conditions, so we can avoid some major clinical pitfalls. Our very first category is the asymptomatic group. And honestly, what's really wild here is the sheer scale of the numbers. Totally collapsed lateral ventricles can show up on CT scans in anywhere from 3 to 80% of patients after shunting. But here's the kicker. The vast majority of these folks are completely asymptomatic. Sure, sometimes they might present with symptoms like true migraines, but those are completely unrelated to the shunt itself. Now, if the patient is symptomatic, we generally have to play detective and distinguish between two main culprits: actual slit ventricle syndrome versus intracranial hypotension. It is so important to note that true slit ventricle syndrome is actually quite rare. It's seen in fewer than 12% of all shunted patients. So you might be wondering, how do we tell the difference between the two? Well, the answer lies in one major hallmark trait. If you're dealing with intracranial hypotension, which basically just means the pressure in the head is way too low, usually from true overshunting, the patient's symptoms are almost always relieved by recumbency. In plain English, if laying flat makes their headache magically go away, you are highly likely dealing with hypotension, not slit ventricle syndrome. All right, let's dive into the heavy clinical stuff. Section 3. SVS pathophysiology, where we really unpack the underlying mechanisms. Let's break this down step by step for subtype A, which is known as the intermittent shunt occlusion cycle. So first up, overshunting leads to the ventricular collapse. Because the walls of the ventricles are now physically touching, that epidermal lining actually occludes or blocks the inlet ports of the ventricular catheter. We call this coaptation. Over time, the patient develops low ventricular compliance. What that means is even the tiniest dilation of the ventricles causes this intensely high pressure, which triggers the symptoms. Eventually, that huge pressure expansion forces the walls apart, reopens the inlet ports, resumes the drainage, and starts the whole painful intermittent cycle all over again. Because this is an intermittent cycle of high pressure, the clinical presentation is very specific. These patients suffer from intermittent headaches that are, without a doubt, totally unrelated to posture, which is a huge difference from the hypotension patients we just talked about. You're also going to want to look out for nausea, vomiting, drowsiness, irritability, and impaired mentation. You might even spot a 6th cranial nerve palsy. Just keep in mind, this specific subtype has an incidence of only about 2 to 5% of shunted patients. Then we move on to SVS subtype B, which is a total shunt malfunction, also known as normal volume hydrocephalus. In this fascinating, albeit tricky scenario, the shunt has completely failed, yet the ventricles somehow remain slit-like. Why on earth would they do that? Well, because they're physically unable to expand. This sheer inability to dilate is due either to scarring, known clinically as subependymal gliosis, or to a really cool principle of physics called the law of Laplace. And here is exactly what the law of Laplace states. The pressure required to expand a large container is lower than the pressure required to expand a small container. Because the ventricles have collapsed into such a tiny, tight, slit-like container, it literally takes an enormous pathological amount of pressure to force them back open. This physical law perfectly explains why the ventricles stay collapsed, even when a patient's intracranial pressure is dangerously high. It's like trying to blow up a super thick, unstretched balloon. Finally, wrapping up our subtypes, we have subtype C. This involves venous hypertension despite completely normal shunt function. It usually results from partial venous occlusion, for instance, right at the level of the jugular foramen in conditions like Cruzon syndrome. But there is good news for patients with this specific subtype. It usually subsides naturally by the time they reach adulthood. All right, moving to section 4, patient evaluation. Let's talk diagnostic methods. When evaluating these patients, we rely on 4 core methods. First, a brain CT or MRI without contrast to actually demonstrate the total collapse of the ventricles. Second is the physical exam, where you'll very often find the shunt valve fill slowly. Third, a radionuclear shuntogram. This is used to confirm distal patency, basically making absolutely sure the fluid is flowing out properly. And fourth, CSF pressure monitoring. This uses either a lumbar drain or a sump drain, where you meticulously track pressure changes during posture shifts and look for any weird pressure spikes while the patient is sleeping. Now, I need to give you a huge clinical warning regarding that physical exam. If you already know the patient has slit ventricles, pumping the shunt valve must be undertaken with extreme caution. Seriously, pumping it can actually aggravate the whole situation by sucking the ventricular walls even tighter against the catheter. Plus, since slow filling is completely expected in SVS anyway, aggressively pumping it adds almost zero useful diagnostic information to your workup. And that brings us to our final section, Section 5, Targeted Treatments and Categorized Approaches. The absolute golden rule for treatment here is simple. Ascertain the category first. But hey, this is medicine, and things aren't always perfectly clear-cut, right? If the patient's category just cannot be definitively determined right from the start, the most common fallback strategy is to initially treat them empirically as if they have intracranial hypotension. If they fail to improve with that, then you move on to other methods. So for those folks in the asymptomatic category, the current standard is generally to just do nothing. Prophylactic valve upgrades or inserting anti-siphon devices have largely been abandoned unless you're already going in for a shunt revision for some other reason. Now, for intracranial hypotension, which is usually self-limited, you're going to want to start with about 3 days of bed rest, some analgesics, and a tight abdominal binder. If the symptom just won't quit, you check the valve's closing pressure. If it's low, replace it with a higher pressure valve. If it's normal, you might need an anti-siphon device, maybe even combined with a higher pressure valve, just to increase the system's overall resistance. But what if we're dealing with true slit ventricle syndrome with intermittent occlusion? Remember, these patients are actually suffering from intermittent high pressure. Your treatment options start with expectant management, since many patients will spontaneously equilibrate on their own. If that fails, your surgical options include a proximal shunt revision to adjust the tubing length, upgrading the valve, or inserting an anti-siphon device to slightly enlarge the ventricle and lift the lining right off those catheter parts. You could also look at performing a subtemporal decompression to relieve the intense pressure, or executing a third ventriculostomy. We also can't forget to account for totally unrelated problems. Let's say a patient comes in with slit ventricles, but they have non-postural headaches that are textbook consistent with true migraines. You definitely do not want to just rush them into brain surgery. In these cases, a trial with migraine-specific medications, like Fiorinol, is highly warranted as your very first step. We have covered a massive amount of clinical ground today, so I want to leave you with this final, slightly provocative thought. Why is it downright dangerous to simply assume that all slit ventricles require a valve upgrade without proper categorization? Just think about the fundamental, night and day differences between an asymptomatic patient, someone with severe hypotension, and someone dealing with true high-pressure intermittent occlusion. I really hope this explainer has given you the precise step-by-step framework to answer that exact question. Keep learning, keep analyzing the data, and we'll see you next time.